What is reverse fourth row pupilloplasty?
It again engages the iris tissue from the posterior to the anterior side. So like you have two things coming in, and then we just railroad both of them together.
So, and then is it more difficult trimming the suture because of where the loop? From the 7th annual winter meeting of the IIRSI in beautiful Amritsar, I'm Josh Young. I'm here with my dear friend Priya Narang. Priya, I had a conversation earlier today with Amar about fourth row pupilloplasty and how it's really changed things. How it's a real sort of dogma shift. What is reverse fourth row pupilloplasty?
It's an honor to be here. Thank you, Josh. And I would like to say that, it's a modification of the single pass fourth row pupilloplasty procedure. Actually, what happens is not only in single pass, but in any other pupilloplasty procedures, we always get the suture ends into the anterior chamber onto the surface of the iris. But with the reverse fourth row pupilloplasty, we get these knots behind the iris tissue. So that's where the difference lies. In the surgical procedure.
So tell me tell me what the actual passes are that I've got to do.
Absolutely. So actually in this technique, I also call it as iris stapling, because at the end of the procedure, you actually do not know where you passed your sutures. So it looks so beautiful. The only difference with this technique is that, we do not pierce the iris from anterior to the posterior surface. We pierce the iris from the posterior surface to the anterior surface on the proximal side as well as on the distal side. So now this is a bit technical challenging. It's not that simple. But what we actually do is that, when we have to go to the proximal side, we take the ninopolypropylene suture needle and we enter inside the anterior chamber, and then we go from behind the posterior iris surface to the anterior surface, and from the other side, from the distal side, where we make a paracentesis and we take a 26 gauge needle and we make an entry, and then it engages again on the distal side. It again engages the iris tissue from the posterior to the anterior side. So like you have two things coming in, and then we just railroad both of them together, and then the suture track is made. So the suture track actually enters from behind, goes anteriorly, goes behind, and it goes off. So now when you take up a Lester's hook or a Sinski's hook and you retract the suture track, and then you take the four throws. You externalize and you take the four throws, and when you pull, it beautifully slides inside, but the difference, you do not get it on the anterior surface of the iris. You get it on the posterior surface of the iris. So that's the difference of this procedure.
That's really, really interesting. It sounds a little technically challenging. Is it made more difficult by the fact that you lose visibility of where the loops are as you're tightening them because they're posterior?
I think that's a good question. What actually happens is that what's different with this technique is that, for example, if you have a big chunk to repair, you have to go from the periphery to the center. Usually what surgeons do, they do the central repair, and then they will just oppose and make the pupil round, and then go and suture the peripheral defects. But with this procedure, you have to first do the peripheral thing and then come towards the center, because you do not have the accessibility of those knots. And you have to cut those knots. So when it goes behind, it becomes a bit difficult. So like if you go from periphery to center, it's so simple.
So and then is it more difficult trimming the suture because of where the loops are?
No, it's not exactly, because logically thinking, we might feel that, okay, it is a bit challenging, but no, it is not, because those knots are just lying there, and you just trim them off, and then it is there, like it's on the posterior surface. It's not difficult.
Then do you have to flip the suture ends?
No, not exactly.
It just goes
not
there?
Exactly. It just remains as it is. But what I would like to say is that, everybody would think that why you want to make things difficult. This is actually, if people know Dr. Price, he has also described one of the procedures to do an iris repair where you do not get those knots in the anterior chamber. This is especially beneficial for patients who are to undergo an endothelial keratoplasty procedure. because those knots, when they are in the anterior chamber, for example, you have a complicated case and you have done the iris repair also for the case, and you are also going to do an endothelial keratoplasty. Now you have those multiple suture knots lying on the anterior chamber, and that's the area where you are unfolding your graft.
Yeah.
The donor graft. So it tends, those knots, they actually tend to rub onto the surface of the endothelial cells
Yeah.
and debride the graft of those endothelial cells. So that was one of the procedures that was described. But with that procedure, the surgeon had to make multiple entries inside the anterior chamber, go from one side to the other, then again come back again and then again. But with this, it's just a single pass, but on the reverse direction. So you get those knots behind, and it works beautifully.
That's super, super interesting. I mean, plus, even if the suture ends are not physically rubbing on the graft, they're still taking up space there, and you've got limited space. I was going to ask you, in your routine fourth row pupilloplasty cases that I caught myself, the idea that there could be a routine, but anyway, if you're not concerned with the endothelium or the need for an endothelial graft, do you still routinely do the posterior placement?
Yes, I do quite a good cases, because it's even cosmetically much more good looking. At the end of the procedure, you can actually not find out where you passed on the sutures, because those sutures are not even detected. Even if you do an anterior segment OCT, you have those sutures going behind the iris. They're even not seen on the anterior surface. It looks beautiful. The iris tissue, it comes along so well. No knots, nothing. Absolutely clean eye.
Fascinating. Would you, for surgeons getting into fourth row pupilloplasty, would you have them start out with the conventional technique, and once they're comfortable, switch to yours?
Absolutely. Yeah, even I would think that, because once you are well versed with doing a single pass, you can easily go on to a reverse fourth row. So that's not difficult then.
Priya, this is so cool. This is so neat. So I want to thank you. First of all, you and I have done a lot of videos. I've done a lot of videos. It is really difficult to describe surgical technique in words, and yet you've done it so beautifully today. I want to thank you for developing this technique, which is wonderful. But most of all, I want to thank you for your generosity with your time with me today.
Thank you so much. It's always an honor to be here. Thank you so much, Josh.
Thanks.
Yeah, it's fun.